Uh, Hi, good evening, and welcome to today's session of Critical Care Webinars. Today is webinar number 130, and today is an important day for all intensivists and physicians, today being the World Sepsis Day. And the topic, keeping that in view, is treatment of gram-negative infections. So the speaker today is Dr. NEHA GUPTA. She's an ID physician, and she works in Fortis, and she has her own setup, and she's very active on the academic circles. She has been a regular contributor to our webinars, and previous webinars by her have been extremely popular with all of you and have been benefiting many students. So this is another session by her, and we thank her for her contribution to our programs. So we'll just start now.
I am Dr. NEHA GUPTA, infectious diseases physician with global experience in infectious diseases of close to 2 decades from the world's best hospitals. Currently, I'm attached with Fortis Memorial Research Institute in Gurgaon, as well as founder of NGSPAS, which is our infectious diseases venture in the heart of Gurgaon. And today I'm going to discuss regarding the treatment of gram-negative infections in the ICU. So infections due to gram-negative bacilli are especially problematic in the ICU. Patients who are admitted in the ICU are very sick, they have multiple comorbidities, and also a lot of times invasive devices are placed in and some procedures are done. Now, as there are several studies which have shown that every hour delay increases mortality, there has been a concept in practice of hit early, hit hard, and this has led to the use of broad-spectrum antibiotics in the ICU, which followed by de-escalation as a principle. But does de-escalation always happen? And this has resulted in this storm of antimicrobial resistance in the ICU. And this was definitely a possibility which was predicted almost a decade back by Dr. Soman, who is who is the father of infectious diseases in India. Now, today I'm going to discuss regarding resistant mechanisms. What are the various global as well as the Indian trends? We're going to discuss regarding the diagnosis of the gram-negative infections and what are the various treatment options and what are the impact on the antimicrobial stewardship as well as the patient outcome. So let's look at the carbapenem resistance across the globe. So when we look at the USA, the carbapenem resistant Klebsiella pneumoniae is close to 11%, and the colistin resistance reported is close to 2.7%. Among the E. coli, it's 2%. Whereas when we're talking about Asia, the resistance among the Klebsiella pneumoniae to carbapenems is more than 50%, and colistin resistance in 2017 was reported to be 3%. Among the E. coli, the resistance is 13%. Now, this is the state of carbapenem resistance rates in India in 2015, as per the reports from CTTPP. So, the E. coli resistance to carbapenems was close to 12%. The resistance among the Klebsiella pneumoniae was close to around 60%. Among the Pseudomonas aeruginosa, which is again a very important pathogen in the ICU, it was again 50% carbapenem resistant, and Acinetobacter baumannii was close to 90% resistant to the carbapenems, resulting in very few treatment options for treating such very difficult bacteria in the ICU. This is one of the data from 2018, and this was again a multi-center study which regarding the antimicrobial susceptibility profile of the gram-negative bacteria. Along with that, the molecular resistant mechanisms were also studied. Among the E. coli, the cephalosporin resistance was 70%. In hope with the SMART study, the carbapenem resistance was 10%, and colistin resistance was 8%. Klebsiella pneumoniae, 60% was ESBLs, 40% was carbapenem resistance, and 37% was reported as colistin resistance. Now, Pseudomonas again, the colistin resistance was close to 5%, and similar was the resistance pattern observed in Acinetobacter baumannii. When we discuss the various resistance mechanisms, so Klebsiella pneumoniae, besides the NDN, the OXA48-like mechanism of resistance conferring carbapenem resistance was also observed. So when we are talking about gram-negative infections with so many mechanisms of resistance, it's very difficult to be positive. And in gram-negatives, there's several mechanisms of resistance, like the efflux pumps, which confer resistance to the quinolones, aminoglycosides, as well as to the tetracyclines, and the chloramfenicol. Then there are certain antibiotic modifying enzymes which confer resistance to aminoglycoside cycloperoxysenase. If there are mutations in the target DNA kinase and the topoisomerase 4, that will result in mutation to the quinolones. Ribosomal mutations confer resistance to the aminoglycosides as well as to the tetracyclines. And loss of purine channels, there is resistance to the imipenen. So here, when we are talking about gram-negative resistance, but the most common mechanism of resistance is the beta-lactamases, which is found in the periplasmic space. And the beta-lactamases hydrolyze or inactivate the beta-lactams. And beta-lactams include the penicillins, cephalosporins, as well as the carbapenems. The beta-lactamases, which confer resistance to carbapenems, are known as carbapenemases. Now, I will use this particular case to discuss the various mechanism of resistance, which we can integrate by looking at the cultural susceptibility reports. This is a 45-year-old gentleman who had this acute pyelonephritis with septic shock admitted in the ICU, and both the urine as well as the blood culture grew the GNB. The GNB was identified as E. coli and with the following susceptibility. Now, with this, what do you think is the mechanism of resistance? So here, when we look at the mechanism of resistance, it is resistant to the third generation cephalosporin, but it is susceptible to the BL-BNI combination like GUPTA as well as cephalosporin syntactive. So this is very likely going to be an ESBL. When we look at the reports of a gram-negative bacilli, this is how we can look at the various antibiotics and then interpret the mechanism of resistance. So when we look at the GNB, first look at the third generation cephalosporin. If it is resistant, then we need to look at the BL-BNI combination. If the BL-BNI combination is susceptible, then it is going to be an ESBL, and ESBL is going to be usually 10-SHV or CTXN. Now, the CTXN is going to be resistant to the amoxicillin clavulanic acid. But if it is belonging to 10-SHV, but it is not CTXN, then amoxicillin clavulanic acid will be susceptible, and this will still be an ESBL, but not a CTXN. If suppose the BL-BNI combinations like GUPTAs as well as the cephalosporin sulfactam are intermediate or resistant, then we need to look at the susceptibility of the carbapenem. If the carbapenem is susceptible, then we need to look at the susceptibility of the cefepime. If cefepime is susceptible, then it's AMSI. If it is resistant, then it is going to be OXA inside or ESBL with some other mechanism of resistance. However, if the carbapenems are resistant, then it is a carbapenemase. And usually, we need to look at the MICs as well. So the automated system, usually the Vitek or some automated system tells us regarding the MIC. So if the MIC of the organism, usually, if suppose it is more than 2, then it is going to be, the susceptibility breakpoint has to be less than 2, especially for Nido as well as the imipenem. And for ertapenem, it has to be less than 0.5. For doripenem, the MIC has to be less than 4. Now, let's look at the various enzymes here. So, when we're looking at the global carbapenemases, the first one which was always discussed, it has been CPC. TBC is usually found in the USA and of course in the neighboring China. India also has some TBC, but it is less than 5%. Then, of course, in India, it was the NDM, which was first described in 2010 from Hinduja Hospital, Bombay. And NDM is the one which is endemic in our country. But besides NDM, there has been this origin and spread of the oxacillinases. So oxacillinase, carbapyramases, it first was described in 2001 in Istanbul, and then subsequently the Oxam 181 has been described in India in 2006 and 7 as well. So when we look at the Oxam family, it is a cluster of basically 11 important enzymes. And these 11 enzyme variants are identified across the globe. So these are the major clusters in the Oxa family. So we have Oxa 1 group, which confer resistance to GUPTAs, Oxa 2 groups as well, then we have Oxa 10 group, and then we have the Oxa 23. Along with that, it is 40, 51, and 58. These are very similar enzymes, and they are found in the Acinetobacter. They're responsible for the carbapenem resistance. And the Oxa 48-like carbapyramases are found in the Enterobacteriaceae. This OXA48-like enzymes, which are responsible for the carbapenem hydrolysis, are usually 14 closely related variants with some amino acid substitutions versus the classical OXA48. So they have very similar structure to the OXA48, and that is why these enzymes are known as OXA48-like cluster or the oxacillinases. So most of them confer resistance to carbapenems. A few of them may confer resistance only to the cephalosporins. Why is it important for us to differentiate or know the mechanism of resistance? This is because if the gram-negative bacilli, they are producing OXA48 or AMC, then they can be killed by the new PLP-like formulation, which is the cephalosporin mavibacter. The cephalosporin mavibacter is going to inhibit the serine beta-lactamases like the KPC, MCPL, as well as the OXA48, and they will not be able to inhibit the NDM, VIM, and M, which belongs to the metallo-beta-lactamases. So the enzymes, so the bacteria which are having NDM will be resistant to cephalosporin mavibacter, whereas the bacteria which are producing the OXA48-like enzymes, MCPs, as well as the KPC, they will be susceptible, and hence this is important for us to know the mechanism of resistance. So do we have OXA48-like enzymes in our country, and what is the prevalence? So this was the data which was published in 2017, and OXA48-like oxacillinases was found in close to 13% was the prevalence. The most common was the NDM, and the co-production of NDM with OXA48 was seen as 28%. It keeps on varying from center to center, and if we look at the data which was in Vedanta, the place where I was working earlier for close to 10 years. Over a period of close to just 6 months, we had 74 gram-negative bacilli. Out of these referred to IV, and out of these 15 were carbapenem resistant. Out of these carbapenem resistant gram-negatives, 20 had only OXA48, and out of the rest of them, the NGM was found in 10. So when we look at the Klebsiella pneumoniae of these GNB, of the 44 Klebsiella pneumoniae, 36 were carbapenem resistant, and of these 36, 20 were carbapenem were only OXA48. So 20 out of the 36 were OXA48. The prevalence was actually more than 40%. More than 50% of the Klebsiella pneumoniae were OXA48. Now, it's very important when a patient comes to us in the ICU to make the right diagnosis for choosing the right antibiotic. And this is especially because all these antibiotics are just hanging by a thin thread which may snap any moment. So when we are choosing an antibiotic, it's much more than just the shot in the dark. And very important is to do a full clinical assessment and send appropriate labs. Clinical assessment is to know what is the site of infection, because sepsis is not a diagnosis. Sepsis is secondary to some other site, some other possibility, and it's important to know that first. So first is to identify what is the site of infection, whether the person is having pneumonia or it's a bacteremia secondary to UTI or intra-abdominal source. Is it an intra-abdominal infection? It is a skin and soft tissue infection with secondary bacteremia, or it is a brain or a CNS infection. So first is to identify what is the site of infection, and then try to identify which is the likely pathogen and the likely susceptibility based on the prior hospitalization as well as the prior antibiotic exposure. And always check that to which antibiotics the patient is not responding. If the patient is not responding to a particular antibiotic, think that which bacteria are not being covered by these antibiotics, and then think about the bacteria and then choose an antibiotic accordingly. When a person or a patient presents in the ICU with any cause, for example, even if it's stroke, if it's a cardiac event, that will result in leukocytosis. And there can also be elevation of the PCP at times. So one has to take multiple points together to arrive at a particular diagnosis, whether first of all it is infectious or non-infectious, and then if they think it is infectious, then choose antibiotics. But these antibiotics have to be initiated only after sending appropriate labs, and the samples have to be very collected appropriately. It should be clean collection with a quick transport to the lab so as to avoid contamination as well as misdiagnosis, and to get the right results so that we can do de-escalation subsequently. So when we choose antibiotics, as I just mentioned, it is based on the site of infection, what is the various likely organisms, their susceptibilities. It can also depend upon the immune status of the patient. So if the patient is very immunocompromised, the neutropenic patient, then we would like to definitely choose a drug which is more stable. But otherwise, in rest of the cases, it will be important to choose a drug which is achieving a concentration adequately at the site of infection. So we have to look into account the various properties of the antibiotic, the PK/PD parameters, that is, what the body does to the drug, and then what the drug does to the body, whether the drug is cytostatic, whether it is achieving an adequate concentration at the site of infection or not. So even if suppose your susceptibility report tells, say for example, with a urine infection that tigecycline is susceptible, then we will not use tigecycline or minocycline, but we use UTI because they do not achieve good concentration into the lung, into the urine. Similarly, if we have amic acid is not a very good drug for pneumonia because it loses its properties in the acidic pH. And again, the trace points of amic acid has been recently lowered down. So for this reason, there's so many factors which we have to consider when we are choosing the antibiotics. So most important again becomes the adequate concentration at the site of infection. We have to look into the side effects, the toxicity of each of the antibiotics, the neurotoxicity or the nephrotoxicity associated with the polymyxin. Tigecycline is associated with sometimes allergy alterations, and so is the minocycline. We can have Ceftiozine manibacterium, which is one of the novel PLP-like combinations. This can result in again allergy alterations. We have to look at the allergy related to the beta-lactams, and sometimes even polymyxin, based on the brand to brand, there can be allergies as well. The frequency of administration, for example, fosfomycin, which has to be administered 4 times a day. sometimes will not be preferred as compared to a drug which is administered twice daily. It depends upon the cost of the antibiotic, and of course, it will also depend upon the ability to achieve source controls. Very important when we are dealing with a patient who is in sepsis, if there is an abscess, if there is a localization, that needs to be drained. And that's when the inoculum of the infection will come down and the antibiotics can act more adequately. Another point about the susceptibility is when we have a gram-negative bacteria in our and it belongs to the spike organisms, which includes, suppose the bacteria is Serratia, Pseudomonas, indole positive Proteus, Citrobacter or Enterobacter. Then for these bacteria, if they are exposed to antibiotics which contain the oxyamino group of drugs, that is usually the third generation cephalosporins, then it results in induction of ANC. And if the BNPLI combination, like the cefoperazone sulfactam, is used for treating the organisms which belong to spikes group, then because of the induction of ANC-BL production, the cefoperazone sulfactam, which appears to be susceptible, will become resistant, and we will have failure of the treatment. Failure will be the outcome. So, in case of spike organisms, avoid cefoperazone sulfactam for the treatment. Pathogen-filled tazobactam won't be used. Now, let's look at this patient who is a 56-year-old gentleman. Now, post CAPG, this patient on day 5 developed a sudden onset leukocytosis and his counts jumped to 29,500. He had severe hypotension and also cardiac arrest. He was revived with the CPR, and at this point, this patient also had a central line. There was a urinary catheter because he had undergone a CAPG, and he also had invasive mechanical ventilation. Now the creatinine was around 1.1, and the chest X-ray was not showing any new infiltrates. This patient was on cefoperazone sulfactam 1.5 grams to LRD. So which of the following is not so appropriate? Send blood cultures from central and peripheral percutaneous punctures in this patient. Remove the central venous catheter. Initiate on carbapenem and teicoplanin, or none of the above. So the correct answer would be to initiate on carbapenem and teicoplanin. When we are seeing a patient in sepsis in the ICU, and we need to again identify the type of infection. So in this particular patient who has a sudden onset leukocytosis, it's important to consider that what is the likely possibility. So whether it is a whether it is a lung-related infection or it is a VAP because this patient had invasive mechanical ventilation. So, or is it secondary to surgical site infection or a UTI? So these are the 4 possibilities in this patient. So we need to look at the points against. So VAP, there was no increase in the secretions and there was no radiological evidence of any consolidation on the X-ray. And besides this, the requirement of the FiO2 was not increasing. Coming to exercise, the wound was completely healthy. There was no active pus discharge. UTI, again, the patient's kidney function test was normal. The ultrasound was normal. It did not reveal any kind of pyelonephritis or perinephric fat stranding. And in the ICU, if there is a catastrophic hypotension and rise in the counts, it has to be a central line related bloodstream infection. So this was the most possible infectious cause of the event which the patient had. Now coming to the line-related infections, since it was this, it's very important that we remove the line, and then subsequently, before removing the line, we must send the blood cultures both from the central as well as the peripheral percutaneous puncture. Remove the central line because that's the source, and we need to escalate the antibiotics as this patient is on cefoperazone sulfactam and is having hypotension. But the choice of antibiotic will not be carbapenem or ticoplanin. If there is a patient who is in the ICU and is failing on the BLP-like combination, the next gram-negative bacteria with resistant will be a carbapenem-resistant GMB. And here, different set of antibiotics with probably polymyxin as the backbone will be used. But if it is a Klebsiella pneumoniae, we definitely have the option for using the normal BLP-like combinations as well. So when we are here, when we're talking about the diagnosis, it is important to send the blood cultures in the right volume. And since it's so important that most of the novel diagnostics are growth-based, that we emphasize on sending the right appropriate cultures. So when we send just one bottle, which is 8 to 10 ml of blood with into the blood culture bottle, the isolation is only 10 to 15%. However, when we send one set, then it is 65%, and when we are sending two sets, it's close to 80%. And when we're sending three sets, then the sensitivity of isolating the bacteria becomes around 95%. So here, if the patient is in the ICU, then we must send at least one blood culture from the central line and the second blood culture from the peripheral percutaneous puncture. This will help us in establishing the differential time to positivity and the diagnosis of line-related infections. Because if the DTP is more than 2 hours, then it has close to 95% specificity for diagnosis of Klebsiella. So in this particular patient, ultimately the Klebsiella pneumonia was isolated from the central line as well as from the peripheral percutaneous puncture. And as we can see here, the DTP was more than 12 hours. And this was the carbapenem-resistant Klebsiella pneumonia with the immunero both being resistant and the MIC more than 16. And when we look at both the susceptibility profile, colistin here is reported as susceptible because this is a old case, but now because there have been changes in the MIC of the colistin, it will only be intermediate. So less than 0.5 is going to be, or less than 2 is going to be intermediate. Now let's look at the peripheral blood culture. Here again, it is the same bacteria, which is carbapenem-resistant Klebsiella pneumoniae, and with the same susceptibility. But also remember that at times we need to look at the susceptibility profile as well as all the reports which are available to us. So in this particular report, besides the colistin, there is also fosfomycin which is reported and it is susceptible. So in this particular patient, with this particular report, the GNB or the CR Klebsiella pneumoniae have two treatment options as per the DSD, which is colistin and fosfomycin. So let's see what should we use. So when we are using our traditional methods, there is going to be delay in choosing our antibiotics because the susceptibility results probably are 48 to 72 hours later. But suppose we have a GMP which is isolated already, then we can use certain tests which can tell us the mechanism of resistance. So here there are diagnostic assays for detecting the carbapenem. We have the expert carba-R, which can be done from the directly from the blood culture bottle or even from the culture plate subsequently. But most important is it can be performed even when the blood culture bottle beeps positive. So here the tag is just 15 minutes, and within 50 minutes we will get to know what is the mechanism of resistance, whether it's oxo-48 only or it is NDM or it's a co-production of both NDM or oxo-48. We also have certain BCID panels which can be performed in the positive blood culture bottle, and again the BCID2 tells us regarding the mechanism of resistance. There have been some CPU detect which are phenotypic growth-based assays, and they tell us regarding whether it belongs to the class A, B, or D. If it is A and B, then we can use ceftazidime naltrexone. If it is B, then ceftazidime naltrexone alone cannot be used. It has to be along with aspirin combination if suppose we have a synergy which is positive. Now, the latest ones are the NG plus kappa 5, and these are the lateral flow assays, and they can be done from the plate. And in this, the advantage is that within 15 minutes, it actually gives us regarding the 5 major. So it's a lateral fluency and it's a rapid test. Within 15 minutes, we get the result that this is oxyportate or this is LDL. Coming to the treatment options and knowing the mechanism of resistance also helps us in choosing the treatment options besides the susceptibility and the MIC of the gram-negative bacteria. So in this particular patient who has got carbapenem-resistant Klebsiella pneumoniae, what should we use? Should we use a combination of colistin with meropenem, which was the standard practice for a long period of time? Should we give polymyxin B alone? Should it be polymyxin B with meropenem, or we need some more information? So definitely we need some more information, which includes what is the susceptibility to fosfomycin, and as we saw that the peripheral blood culture grew carbapenem-resistant Klebsiella pneumoniae with fosfomycin susceptibility, and we need to know the mechanism of resistance as well as the susceptibility to ceftazidime alibactam. So these are the two additional information which are needed. So we have been using colistin, which is a prodrug, for a long period of time. But there has always been confusion regarding the doses of colistin as well as the PKPD. So when we look at the PKPD of the 1 million and the dose, so 1 vial of colistin is 1 million unit, which is equivalent to 18 milligrams of the CNS and 30 milligrams of the colistin-based activity. Now, when we are looking at the AUC by MIC of colistin, a pre-drug concentration or pre-AUC by MIC of 12 or a AUC by MIC of 24 is associated with 1 log K. So here, this can be achieved with a colistin steady state average of 2 milligram per liter, which will generate a AUC of 48, and it will correspond to the AUC MIC of 24, then the MIC is less than 2. So it's important for us to have a level of colistin steady state average of 2, which is usually expected to be achieved with a loading dose of colistin followed by maintenance doses with this particular formula. However, in a critically ill patient, there are so many changes which happen related to the BT capillaries, then there is alteration in the protein binding, increased cardiac output, and this results in augmented clearance. So the hydrophilic antibiotics and antibiotics which are very tightly or highly protein bound, especially flucloxacillin, artepiram, teicoplanin, they may have subtherapeutic concentration into the blood. And also we know the same regarding the beta-lactams. And similar is the possibility even with colistin. So this is the probability of target attainment of colistin, and based on a population-based kinetics. So here we can see when the loading dose of colistin is given, it is directly dependent upon the creatinine clearance. So when the creatinine clearance is more than 80, then the probability of achieving this colistin steady state average of 2 drastically goes down. And in patients who have got this profound neutropenia, in fact, profound neutropenia, then the target, the PKPD index is 2 times higher. Now that cannot be achieved with the standard doses of colistin which we use, and that is why there was a shift from the CNS to the polymyxin B. So CNS is a prodrug, which is basically it is converted into colistin by removal of the methane sulfonate molecules, and this conversion itself may take around 5 to 6 hours. And this colistin is the active colistin with a very long T-half of close to 14 hours. Whereas the prodrug has a very short T-half of just around 2 2.3 hours. Now, this conversion of cold CMS to the active colistin itself has a 20-fold variation and, in fact, can be different from brand to brand. The colistin has, the active colistin has majority and non-renal clearance, whereas the CMS is associated with 60% has got a renal clearance. And that is why the doses of colistin have to be modified or reduced in patients who have got decreased in the creatinine clearance, because that's when there is accumulation of the prodrug, which also further results in the nephrotoxicity. When we talk about polymyxin B, it is an active drug, and it gets since it's an active drug, there is not much of variability. The interpatient variability is just 3 to 4 fold across wide range of the various kidney functions also, and it gets completely reabsorbed from the kidney tubules. So polymyxin B, because it's an active agent and does not require any conversion, can act straight away in the gram-negative infections, and as in critical patients, every hour matters. Using an active agent is better. However, polymyxin B is also associated with certain toxicities. So, very importantly, it is associated with neurotoxicity, which is more than the CMS or the colistin, which is a polymyxin B. Also, the infusion has to be over 2 hours, and it is not stable beyond the 2 hours. If suppose it is given earlier as a shorter infusion, then it will result in more neurotoxicity. And also infusion-related side effects will be much more. The nephrotoxicity is definitely much lesser. It's probably 1/3 of the colistin, but it is not devoid of the nephrotoxicity. So there are issues with polymyxin B as well, and that is why there has been a switch from polymyxin B to the safer novel VLV-like combinations. Now, when we are using antibiotic in the ICU, should we use monotherapy or should we go for combination therapy? So in the ICU, as the mortality score is higher, so in such patients, a combination therapy is in fact better, because that is associated with a higher survival rate as compared to monotherapy. In patients who are in the ward with a low mortality score, there's not much of difference between the monotherapy and the combination therapy. So in the ICU, definitely a combination therapy will be preferred. So earlier there was this concept of using colistin or polymyxin B with high dose meropenem, which was given as prolonged infusion over 3 hours. And the concept was that even when we are giving this prolonged infusions over 3 hours, it is probably able to cover the organisms with the MIC reaching up to 32, or say for example, up to 16, right? But in our patients, usually the MIC is more than 16. So this particular combination of polymyxin B with high dose meropenem may not be better in our set of the gram-negative infections which we see. Especially for Acinetobacter, this combination is not better. Again, for the Enterobacteriaceae, if they have more options like susceptibility to, say, fosfomycin, or if there's susceptibility to tigecycline, or of course to ceftazidime-avibactam, or synergy positive to ceftazidime-avibactam with astronam, then these will be better options depending on what is the size of infection. If it is an intra-abdominal infection, then tigecycline will be a better choice. If it is a urine infection, then using fosfomycin will be a better choice, or using the ceftazidime-avibactam, if susceptible, will be a better choice, because these drugs achieve a high concentration into the urine, and tigecycline does not. So when we look at the various treatment options, coming to colistin and meropenem 6 grams per day, because there are issues related to achieving an adequate colistin steady state average of 2, which is very less when the creatinine clearance is more than 110, colistin is not the drug of choice. Poly B definitely will be preferred because it's an active agent. But for combination of poly B used with meropenem is not preferred because it is likely to work when the CRE-MIC is preferably between 4 to 8. And coming to fosfomycin susceptibility, this was susceptible, and this is also a good treatment option for us. It is a cycle antibiotic. It is a very small molecule, so it has a very good penetration into the various cells. However, we must remember that although it is active against the gram-negatives, it is no activity against the Acinetobacter. So in patients who are developing infection or a VAP, and if suppose A Bomani rates are high, then empirically fosfomycin may not be a good choice. It has to be polymyxin B along with say minocycline or tisacycline, depending on the susceptibility. Minocycline is a very good drug for the lung infections and has got activity against the Acinetobacter. The fosfomycin has a very good penetration, has very high utility levels, doses 16 to 24 grams per day, and doses have to be modified with creatinine clearance of less than 40. There are certain adverse events related to fluid overload and high sodium and low potassium. This is one of the proposed algorithm for empirical combination for the treatment of CRE infections in critically ill patients. And based on the site of infection, which includes bloodstream, lung, GI, bone, CNS, urine, we should choose our antibiotic. And of course, to this, ceftazidime avibactam will be, or a combination of ceftazidime avibactam with astronam would be one of the additional or the treatment options. Ceftazidime avibactam is a novel beta-lactam beta-lactamase inhibitors, and the avibactam, if you look at the beta-lactamase BL-beta combinations, if you look at the various novel BL-beta combinations, the avibactam belongs to the DACO-based inhibitors. And here, the beta-lactam is the ceftazidime, and the beta-lactamase inhibitor is the avibactam. And the other DACO-based beta-lactamase inhibitors include the relibactam, which is imipenem relibactam, and nacibactam, which is meropenem nacibactam. Then we also have the other boronic-based beta-lactamase inhibitors, but they're not really available with us in India. This is one of the charts which briefly describes the various treatment options which we can use in case these are the mechanisms of resistance. So suppose it's an ESBS, we can go for the BL-beta combinations like the cefoperazone sulbactam or the patricin tazobactam. If it is an MCBS, then of course it has to be we can go for cefepime, or we can also go for ceftazidime avibactam or the carbapenems. If it is a KPC, then we can use ceftazidime avibactam. If it's an oxal 48, still we can use ceftazidime avibactam. If it's an Indian, then ceftazidime avibactam will not be effective, and there the treatment choice can be astronam avibactam once it comes into the market, or for this, it's basically the polymyxin-based therapy, which is the cornerstone. And for pseudomonas as well as for the Acinetobacter, we have to rely predominantly on polymyxins, as both ceftazidime avibactam and astronam avibactam do not cover the Acinetobacter. The other treatment option can be this cefiderocol, which can have activity against the pseudomonas as well as against the Acinetobacter, and probably it's going to arrive soon in the Indian market as well. Coming to the impact of using the right treatment option on the antibiotic stewardship as well as the patient. Let's look at this with this particular example. Now, this is a 66-year-old gentleman who had this coronary artery disease with COPD. When he was admitted in the ICU with this acute onset breathlessness, and as we can see, there was a pneumonia which was on the left lung. Now the sputum culture was sent and the GNV grew, and we were waiting for the PSD. But since we knew that it has its own GNV, we quickly performed the OXA48 in this patient, and which it detected the OXA48. So the expert CARVA-R was performed, OXA48 detected, and ceftriaxone naltrexone was initiated, and patient had clinical cure. Now, the later, when the sputum culture report with DSP was obtained, it was Klebsiella pneumoniae, which was again carbapenem resistant, with susceptibility to fosfomycin as well as intermediate to colistin. This was an old report, so it will be colistin susceptible at that time. Now, here, the other option would be colistin and fosfomycin. This will be very expensive as compared to just the monotherapy with ceftriaxone avibactam. So we could avoid colistin and fosfomycin both. And there have been studies which have shown that colistin versus ceftriaxone avibactam, when they were compared, then ceftriaxone avibactam was associated with lesser mortality. So the mortality was just 9% as compared to 30% mortality with colistin. And there were better outcomes which were observed with the ceftriaxone avibactam. The choice of antibiotic will depend on the site of infection, as I have described earlier as well. This is a snapshot of the antibiotic options for the gram-negative infections with suppose it's a patient. What they have mentioned that for a lung infection, aminoglycoside should not be used, especially as a monotherapy. And when we do not know that what is the likely susceptible organism, then it is better to start with a combination therapy initially after sending appropriate samples, especially when the resistance to one antibiotic is more than 10%. So in our setting, when the resistance to the Pseudomonas, to polymyxin B, is more than 10%, again, Cas-RV resistance is also increasing. Better to start with a combination, and then probably we can de-escalate down once the patient improves. This ceftriaxone avibactam is a combination, as I just mentioned, it is a novel BL-BLI combination where the avibactam is the diazine bicyclooctane, DAPO group, and it binds irreversibly to the class A KPC, class C MC, and class D beta lactamases, which is also OXA48. It does not inhibit the MDS. Since it is a beta lactam, it is silent, and also the PKPD is time above MIC. It has to be given more frequently, and the dose is 2.5 grams each hourly, which is usually in 100 ml of normal saline over 2 hours infusion, and the doses have to be modified with the creatinine clearance of less than 50. Remember, it has no activity against acetylcholine. So if the ICU has high incidence of E. baumannii, then this should not be used empirically. For certain infections, again, let's say Stereotrophomonas and bacterial fragilis, Listeria monocytogenes, and this GPC are again not covered. So if it is used for the intra-abdominal infection, then we must add metronidazole. Now, this was not the case when we were using ceftriaxone sulbactam or pathocystin tazobactam or even carbapenems, because they have activity against the anaerobes, and there is no need to add additional metronidazole with the carbapenems or with the ceftriaxone sulbactam. But with ceftriaxone avibactam, additional metronidazole to cover anaerobes for intra-abdominal infection should be used. It has been FDA approved for complicated UTIs, complicated intra-abdominal infections, and happen back. And there are certain phase 3 studies which include the recapture, reprise, as well as the approved studies. Adverse effects includes elective alterations, thrombocytopenia, C. difficile colitis, as well as the neurotoxicity. Now, this is one of the tables which briefly summarizes that if suppose we are suspecting Enterobacteriaceae, the first preferred choice would be Cas-RV, if it is only oxalic. If it is oxalic with NDN, then use synergy testing and then go for streptozidine avibactam with astronam. Alternative therapy will be polymyxin-based therapy in case there is allergy to the beta lactams. For Acinetobacter, polymyxin-based therapy with a combination of minocycline and sulbactam, which is usually 9 to 12 grams per day. Rifampicin is not used in India because of the concern with tuberculosis. And again, TG-cycline should not be used even for the HAPN-VAP as per the IDC 2016. If there is other bacteria like the Elizabeth kingiae or Stylotrophomonas, Elizabeth kingiae TMPS mixed minocycline, Stylotrophomonas TMPS mixed levofloxacin or minocycline can be used. So this is the suggested workflow for the gram-negative infections in the ICU. So if there is a GMP which is activated, do a gram stain, or if there is a facility to do Maldi-Talk, perform that. If it is an antibiotic, then also perform the lateral flow assays or the expert CARBA-R to detect the carbapenem resistance or not. And if it is carbapenem resistance, then we can based on the mechanism of resistance, we can choose an antibiotics. If suppose the carbapenem resistance is not detected, then we can go for de-escalation of the antibiotics as well. So I'll go on to this last case for discussion, which is a 74-year-old gentleman with cerebral vascular disease. He was initially in septic shock because of the dry gangrene, underwent amputation. The first when it was amputated from the gangrene side, used Pseudomonas aeruginosa. Now, at this, he was added on colistin and tetracycline. Now, 10 days into the therapy, he developed again hypotension as well as leukocytosis with counts jumping from 14 to 27,000, and he required anadrones. And that's when an IV reference was sought. We saw that the surgical site was fine because that is one of the sources of infection. But the central line was showing pus at the exit site. So this was in place for close to 17 days, and there was a pus at the exit site. And we quickly performed the gram stain, which showed these budding leaves, giving a clue towards the candidemia. Now, when we looked back again at the culture report, now this was Pseudomonas aeruginosa, and look at the susceptibility. It is susceptible to the third generation cephalosporins here as well as to ciprofloxacin. And since colistin was susceptible and amino susceptible, it was stigma. So initially that was given, and somehow I think tetracycline was also added. So we must look at the susceptibilities and choose drugs which have got narrower spectrum or narrower impact and less collateral damage. And when we use antibiotics in a clinical practice, it's important to remember that there are certain bacteria which are not covered by certain antibiotics. So if a patient is on a particular antibiotic and is deteriorating, then think of the bacteria which are not covered by these antibiotics. So here it will be for colistin. It has no activity against Proteus, Providentia, Morganella, Serratia, Burkholderia, Salmonella, GPCs as well as anaerobes. Ceftazidime avibactam I have mentioned. Again, fosfomycin has no activity against the Acinetobacter, and imipenem has got no activity against the Stylotrophomonas. So if a patient is on imipenem, then there's a possibility of colistin resistant, carbapenem resistant antibiotics as well as imipenem, and a completely different class of agent, which is TMPSM, which has to be used. So to summarize, infectious diseases, they keep on varying from specialties in the presentation approach as well as the management. And there are several factors which impact the choice of antimicrobials, and it keeps on varying from specialty to specialty as well as from syndrome to syndrome. We must perform appropriate investigation, which may be either invasive, before starting effective antimicrobial therapies for making a specific diagnosis and choosing the appropriate therapies, which are the basic tenets for antimicrobial stewardship as well as infection control. And ultimately, there is no substitute for a good history, clinical examination, as well as interpretation of the lab results. And all this is perhaps the ray of hope in this dark landscape of antimicrobial resistance. Ultimately, for all of us, we need to collaborate with the various specialties for the right treatment options and treatment decisions. Thank you so much.
Thanks, Dr. Neha. That was a wonderful presentation as usual. So if there are any questions, I'll be happy to take them. So no questions have come up. So I think we shall close the session. Thank you, everybody.